Everybody, I just am joining for a second to let you know that the department meeting, the faculty meeting is almost over. I didn't want anybody to leave to think that we'd forgotten you, but just let's hold on 1 minute. I think I'm the warm-up act, so we will get this started in just a second. So I'm sorry that we are a little bit late, but you know, when we ask people to start talking, they just don't like to stop, which is wonderful. So hang on.
Dr. Marcel has been prolific this year in terms of funding from both the Assistant Research Director. In terms of maintaining a world-class training program, which is also one of our goals, we're
All right, this is awkward. It's how we do it.
It's okay. People are still gathering.
Have any good jokes, David?
Yeah, it's so good to see you. Do I know any good jokes?
Yeah.
Every time I think I have a good joke, I test it on my kids and they tell me it's not a good joke. And so I've been alerted to the fact that dad jokes are just not jokes anymore. They're like its own category of communication.
Kind of true.
Yeah. So let me see. There's the one about my friend who had to leave his job in the orange juice factory because he couldn't concentrate. It's a famous
Oh,
one.
that's terrible. Your kids are so right.
There's there shouldn't be, but there are plenty more where that came from. But the kids, the patients think they're funny up until about the age of 6.
Or
And
they
then,
talk back, actually.
yeah, that's right. And then between 6 and 12, they just stare at me blankly. And then between 13 and 18, I get an eye roll, which is the extent of my neurologic exam. I shouldn't, I shouldn't say that with Brenda about to join, but my neurologic exam in teenagers consists of inducing an eye roll. And if it's synchronous, then those cranial nerves are very intact.
Intact. All right.
It's let me see, I just going to log on in 2. Brenda's joining in 2. So
Is that what she said?
yeah, she just texted me. I'll just say no problem. Folks are still logging on. I think that's true.
Yep.
And I'm telling dad jokes. Let me see. We have another dad joke.
In that case, she'll hurry up.
Yeah, exactly. out of
Desperation.
sympathy, really, for the there's a CRNA who collects dad jokes for in the OR.
The New York Times Sunday crossword puzzle is often full of dad jokes, which is embarrassing because I can always get them.
That's so funny. So he's got a little notebook. How do you throw a party in outer space? You plan it. That's a pretty good one.
I said that. That was great. Coca's a good joke teller? I didn't know that.
No, is Coke? Yeah, Coke is an excellent joke teller. That's absolutely true.
All right. I have think they just finished, so people should be joining.
I went to buy some camouflage pants, but I couldn't find any. What did the grapes say when he got stepped on? Nothing, just let out a little wine. It's pretty good.
All right. I see people from the faculty meeting joining. As soon as Brenda joins, we can get started.
Yeah, we boosted the attendance significantly.
Let's see.
I'm
Dr.
here
Allen,
now, yes.
there she is. All right, great. Thank you
Please
so
go ahead.
much. So let's go ahead and get started. And I am honored to be able to open up this State of the Children's Center and Department of Pediatrics grand rounds for this year. I am sort of yesterday's news at this point, but that's cool because I'm going to talk a little bit about the year that has passed. And then Dr. Banwell will lead us through, Dr. Hackham and Dr. Banwell will lead us through what's coming next. And that's really exciting. So we always talk about our mission, and I'm not going to give a mission moment here because I'm worried about the time, but we always talk about our mission. And I love to put it up to remind us, this is what we're trying to get done. And this is what we do well. I don't need to read it all again, but it is how we see ourselves. And it's such an important mission that I just think it's worth reviewing every time in case you have a question about what we're doing here. And it's a lot of important stuff. I want to put up this slide just because I think one of the challenges in this presentation specifically, and also in the work that we're all trying to get done, is the Children's Center and the Department of Pediatrics often feel to me certainly, like exactly the same thing, but they're not. So the Children's Center is part of the health system and part of, we are integrated into Johns Hopkins Hospital. The Department of Pediatrics is on the School of Medicine side, and the health system and the School of Medicine are both part of Johns Hopkins Medicine and thereby part of Johns Hopkins University. But they're not exactly the same thing. And it's interesting, in the last year, one of the reasons I'm focusing on this right now is as we think about what happened in the last year, it's important to know that both the School of Medicine side and the health system side were engaged in incredibly challenging transformations. And we, as the Children's Center and the Department of Pediatrics, we're really having to dance two dances, trying to make sure that we were reacting to and accommodating and working well within both series of major changes. In the School of Medicine, it started with a recognition that the way that we were accounting our dollars and the way that we were doing our accounting was sort of really not serving us in the way it should. But then, in that work, it identified a massive deficit in the School of Medicine and a large deficit, historical deficit in the Department of Pediatrics that we have had to recover from, fix, reevaluate, redesign, sweep money from here, put it there, really did a huge amount of work trying to fix the budget side on the School of Medicine in the Department of Pediatrics. That work is ongoing, but we've done tremendously valuable work this year. At the same time, though, the health system was really struggling because it's just really difficult to sort of make any money or break even with the way that medical care is paid for in the state of Maryland, specifically, especially academic medicine and especially pediatric medicine. So I love this notion that we were really caught in a maelstrom of, two different, very serious, very important strategic changes. And so I'm impressed. The reason I'm focusing on this is I'm so impressed that as a children's center and a department, we held our focus. We kept our work and we held our focus. And that's what I want to talk about very briefly. So every year I present this I have presented this in terms of what is the Johns Hopkins Medicine strategic plan. I'm happy to say that we're going to get rid of these 6 octagons now. We have a new strategic planning framework, but for last year, we're really going to, it's fair to go back and look at what we promised to do last year and to see what we got done. And especially I want to remind everybody what we got done in light of the challenges that we were facing. So goal number 1 was make Hopkins easy, which always sort of a joke, make Hopkins easier. Sorry, my fingers are touchy here. And what we did last year, what we've really been focusing on is expanding insurance access. So we've been talking about expanding access to Medicaid. Half the children in the country have insurance through Medicaid, and Hopkins does not participate with all of even the state of Maryland Medicaid program. So we've really been banging that drum hard. And I feel like this year we've really gotten a much better reception from the School of Medicine and from the system about the importance of trying to open to more Medicaid. That's going to make a big difference for us and for our patient population. We are trying to improve capacity. And the development of our new capacity command center has been really remarkable in enabling us to use our beds more effectively. I want to shout out to our marketing and communications team because they really stepped up this year. It's amazing how much their local and regional marketing campaign has made a difference, but also their real focus on getting the Hopkins name out, especially Hopkins Pediatrics. I mean, they've been doing a fine job in making sure that all the work that we're doing gets national recognition. We've been looking at our outpatient clinics, and part of this is forced on us by the funds flow transformation that's requiring us to look at RVU generation, and everybody's answer was, yeah, but our clinics are so inefficient. And finally, the system and the School of Medicine said, yep, we get it, we need to do better. So I think there's more to come on that, and it's exciting. I want to thank Alicia New and her team specifically for making the academic mission a little easier for people to navigate. It can be a terrifying process. And I really respect and admire the way that Dr. New and our promotions committee have worked really to help people to understand. So making Hopkins medicine easy is a forever goal, but I think we've been taking important strides. Support the well-being of our people in our communities. Workplace violence remains a tremendous problem. And we have not solved workplace violence, but I love the persistence. And we keep recognizing the importance of this work, and we have been remarkably persistent in saying, we can't let this go. We have to keep working. We have to keep trying. We need better safety precautions. We need more staff. We need to make this better. So I want to thank the people in the Children's Center specifically who have really, and this is both nursing and child life, patient family centered care, really focused on, we cannot let this go. Workplace violence is very important. Our DEI programming is impressive. I think we are in the Department of Pediatrics currently the most diverse department in the School of Medicine, which is cool. This issue of working with state agencies, we promised to do that. We've done a very good job. This problem is absolutely not fixed, but I really admire the group of people who got together to say, okay, we can't fix this problem of having DSS people in our children's center who don't need medical care, but we can make their experience better. We can stop feeling so sad for them, where we can stop making their experience so awful. And we really did great work in trying to promote a better experience for these kids who are stuck here with in dire straits, sort of. I want to thank the RISE program, the nursing-led resilience programs that are cool and funny at the same time. The new restorative space will make a difference. So I think we're, again, meeting our goals and pushing forward. Pushing the boundaries of science and education. We talked last year, we promised ourselves that we would get the CMSC clinical research space arranged. That has not happened. And I think the obstacles are becoming more and more clear. But what we have done is, in our typical path, figured out a way around it. So if we can't use the space the way we wanted, I think there's been some really great discussions about how to use that space maybe for informatics, maybe for some of our data programs, to use this space effectively, even if it was not exactly for the clinical research that we'd hoped. I'm so excited about the new Children's Center Advisory Board because I think it will help us to bring advanced philanthropic support for research to the Children's Center and the department. That's really important. We need a lot more. We have so many people doing such brilliant work. We need more support, especially to create a better pipeline, to bring in new investigators and to keep them here. I'm going to go on through. You guys can read some of these on your own. Improve the quality and affordability of healthcare. I think our quality and safety team deserves a lot of recognition. And I know that only because we've seen their effects in the Children's Center, but also because the hospital, and I think even the system, have recognized that the Johns Hopkins Children's Center approach to quality and safety is a model. It's such a model, I'm always worried they're going to steal our people, but it is a real model, for a role model for Hopkins and for the system. And I appreciate also that in addition to our operational quality and safety program, we have a revitalized division of academic quality and safety. There are great things to come. So this is the work we promised to do, and we have done that, continue to do it, and we will continue. So other things that we want to get done that we haven't been able to yet is that last one, the redesign of our inpatient and ED focused behavioral health. It's a really great package, a really great plan. It's approved but not funded, but we're not letting it go. We're going to keep pushing and keep asking and making sure that the school, that's a system, and the hospital understand the importance of improving the way we can approach behavioral health. Work like one organization. I love this one because I think that we need to be sort of demanding of our own relationships with parts of our system. So we do need to work as one across. You've heard me talk before, and I will keep talking about the importance of the voice of pediatrics in Johns Hopkins medicine. If we work like one organization, we are stronger, and we are a stronger voice for pediatrics. So I think that our work with All Children's is very important. Our work with Mount Washington and their new leadership has been very valuable and will continue to help us raise the voice of pediatrics in Johns Hopkins medicine. I mentioned already the Capacity Command Center, but one of the things that is special about it is its ability to collaborate with the Adult Capacity Command and also across all the beds, pediatric beds in our system. So that's really cool. I want to celebrate Kylie Gero-Histradoulis' role as the new ADON for pediatric ambulatory, again, across our system. So that was something that we have been missing, and we now have a voice across, looking at pediatric outpatient clinics across the system, which I think is marvelous. Let's see. And aim for precision. This is a lot about our informatics program and precision medicine program. And I want to celebrate Kaiser Aziz taking over the role of the Chief Medical Informatics Officer. He's really got a lot to offer, and it's already making a big difference. So part of the funds flow transformation requires that we do a lot of good work in using real-time provider data. And I think we all need to get better at that, but I think it's available to us. We just need to get a little bit more adept at using it. I talk a lot about the importance of having pediatricians and pediatric practitioners at every important table in the system and the School of Medicine. And I love this slide. We are doing it. We need to keep doing it. I think it's more important than ever that we make sure that there is a pediatric voice at every important hospital table, system table, integrated program table. We have to speak for children. That's the only way that the voice of pediatrics in Johns Hopkins medicine will stay strong. So with that, I will tell you that the state, from where I sit, the state of the Johns Hopkins Children's Center is strong, is mission-driven, is persistent, forward-thinking, collaborative, achieving. We are patient family-centered, we are problem-solving, we are leading, challenging, we are curious, and honestly, forever and ever, we are inspiring. So with that, I want to say also that we are welcoming, and we are excited to see Dr. Brenda Banwell take over the department and be co-director of the Children's Center. There's a lot of wonderful things to come. So thank you, everybody.
Thank you very much, Maggie. I think, David, you're going to go next, and then I'll have some other remarks.
Yeah, that's wonderful. So let me start before I share my screen. Wow, it's wonderful. 217 people. That's amazing. Thank you all for taking the time this afternoon to join us all. Also, a huge thank you to Dr. Moon. You've been an incredible partner over the last many years, and your impact is broadly felt, appreciated by all. And we're deeply grateful for the hours and hours and hours that you put into this. And much of it after hours, where you and I seem to be in constant communication. So thank you for being a wonderful partner. There are others to thank, and we will continue to thank them over the next little bit. Let me share my screen. And if you'll indulge me, I'm going to place the, you don't care about that. I'm going to place, I'm going to present in this mode. You can see I've only got 4 slides. Can someone give me a thumbs up? Peach Chiefs or Brenda? Great. I want to start, and you can see I've only got a couple of slides. I want to start with a story. This is an amazing picture of a really remarkable young man called Matthew, who is at the piano, and he's actually playing it. I met him when he was in a much, much sicker state. And in fact, he was dying. And his story is really the story of the Children's Center. His is a story of pediatric surgery, of course, but also pediatric subspecialty care at its finest. Pediatric ID, pediatric renal, pediatric GI, of course, the pediatric intensive care unit, and our incredible nursing colleagues and rehab colleagues that together represent the very best of what we do. I met Matthew when he was in the ICU, where he presented with a terrible bacterial colonic infection and developed multi-system organ failure and was cannulated for ECMO and was decannulated and continued to exhibit deterioration. And the story is best told, you can see how it ends, thankfully. The story is best told by his mom. And so I'm going to play just a snippet of a story that she told that was played on the air during Radiothon. And the entire story is 4 minutes. I'm only going to play the first 90 seconds. And if someone could give me a thumbs up when this plays. Here's Matthew's mom.
All the times you thought you'd never make it through, felt just like the world just turned its back on you.
Hi, my name is Jennifer, and I'm Matthew's mom. We came to Johns Hopkins Children's Center because Matthew had multiple organ failure from an E. coli infection. It was a right decision.
Somehow it's all part of the plan, journey.
My son's kidney failure started to show worse and worse, so they got him on the peritoneal dialysis, moved him to pediatric intensive care.
It's the journey. It's the gift to where you're going to.
2 days later, his lungs started to fail. He can't breathe. And another 2 days, his heart completely stopped. His lung failed, and then his heart failed. He was rushed to the operation room so many times.
It's a hell of a ride.
The doctors, they worked really hard, and his heart woke up. It's a miracle. He got off the ECMO, and we were so overwhelmed with the success. But the next day, a CT scan showed that he actually had a stroke that affected about 20% of his brain, and that caused his left body paralyzed.
So far, no big plan. Journey.
They also found his bowel is not doing good, so they have to have open bowel surgery. After that surgery, he had intensive bleeding. The lead doctor of the PICU told me, Matthew could very quickly die. We need to get him to the operation room again and try to stop the bleeding. We might succeed, or he would die immediately on the operation table.
Step along the way. Journey.
My husband said, "We trust you." My husband and I were praying outside the ICU, and the security lady approached me and held my hand. And she said, "Your child is in God's hands." The doctors came in before he even got close to us that we can hear him. He gave me a thumbs up. I knew it would succeed. It was a miracle.
I think this story really exemplifies what we do here at the Children's Center. Those were some rough days for Matthew and the blood bank and for his family. But you can see this is what makes it all worthwhile. So thank you to everyone that participated in the care of this child. The family are incredibly grateful. He has a long way to go. You can't see his various different stomas and G-tubes and things like that, but he's making great progress. So about that progress, just in the next few minutes, sometimes the patients tell the story and sometimes the numbers tell the story. And so I'm here to do both. First, if you look at how we've done as an operative enterprise, we've been very busy. And despite all those financial pressures that Dr. Moon referenced, we've enjoyed 6% growth year over year. This growth has been across the various different specialties, despite incredible challenges in staffing, in recruitment, in general turnover that you see in surgical units. I particularly point out the work of Peds GI, who contributed incredibly to these numbers under Maria Oliver Hemker's leadership and maintained growth despite incredible personnel changes. Neurosurgery, orthopedics, otolaryngology, plastics, urology, general surgery, and cardiac, just incredible work. That work could not have achieved its success, and I think this growth is a measure of success, without these individual units as well. And that's why they're actually on top of the numbers. Peds anesthesia, none of this work can be done without our anesthesia colleagues who have worked mightily to sustain this growth and really allow this growth despite turnovers and really strong recruitment by Sapna and her team. The Peds Hospitalist Service contribute tremendously to this activity, especially with our ortho and neuro patients. Child life, none of this happens without patients coming to us, and they come to us because they find an environment of care that's conducive to growth, and that's a reflection of child life. And of course, social work and all that they do to get patients in an environment outside the hospital that allows them to reach their full potential. Our pediatric pharmacists sometimes don't get the attention they need, but sometimes they call us out for when we get things wrong. But thank you to our pharmacists, our medical office coordinators for making the bookings work and getting the insurance clearance. In no particular order, and nursing is probably right on top. Think of the impact that this has on our nurses throughout the hospital and how they've been able to facilitate this growth and stay true to our mission. Tremendous thanks to Dawn and her team. The PICU, as was reflected in Matthew's story, but also the pediatric emergency department, who are working under really incredible challenges, as the high capacity indicates. We sometimes forget the RT, PT, and OT colleagues that sustain this growth. And a particular shout out to the quality and safety teams under Dave Stockwell, Rahul Koka, and Ann Kane that continue to push us to make sure that we're evaluating quality and safety in everything we do. So hugely appreciative to these teams for which these numbers tell a bit of the story. I do want to give recognition to the pediatric surgical divisions and their kudos in front of this large group of colleagues. And when I asked each of the divisions to send me their kudos, I literally got slides and slides from each, and we'll be presenting that at Surgical Cabinet tomorrow. But I'm restricting one line to each, and so I will call them out. Particularly calling out the Pediatric General Surgery Group, Sean Konisaki, if you see him, give him a high five for his new R1, and Alex Garcia Clincapiello for the growth of the robotic program with our peds urologists, is now the busiest training program in peds robotics on the East Coast by a lot. Urology, plenary sessions by Heather DiCarlo, the very famous Duckett lecture by John Gearhart, and Dr. Wu is the program director now for the urology residency. Tremendous recognition. Otolaryngology, growth of the cochlear implant program under Dr. Jenks, and recognition of Dr. Emily Boss, who I actually saw on the call as our new division chief in Peds Oto, taking over the incredible work of Dave Tunkel, who he keeps telling me is not going anywhere yet. Neurosurgery, tremendous research growth under Dr. Jackson, site PIs for programs in hydrocephalus, Chiari malformations, and brain tumors. And we have a president in our midst, in Dr. Robinson, leading the AANS and the elect of another major organization. I don't want to get it wrong. Cardiac surgery has had some turnover, but despite with the departure of Brett Mettler and the active search for his successor, despite those challenges, they've had sustained clinical activity. Dr. Sen, Gottlieb Sen, is a UNOS primary surgeon. And please high five Dr. Cho if you see him for his multiple new grants, R01, DOD, and others, reflecting the real creativity of Dr. Cho, but also the environment in which he works. Plastics, new division chief, and Dr. Robin Yang, who is also the vice chair for clinical affairs, and tremendous collaboration with Dr. Yang's group and the general surgeons in these incredible burns that we've had. And then orthopedics, tremendous growth of sports medicine under Dr. Lee, and growth of national spine referrals under Dr. Sponseller. And so in the very final slide that I'd like to share, where are we going? And as Dr. Moon mentioned, and as I think we'll hear about shortly, we are in a true inflection point in our journey in the Children's Center and certainly in pediatric surgery. And so growth of the Children's Center and priorities for pediatric surgery are one and the same. We held a retreat last fall for pediatric surgery growth, and these for which the Children's Center leadership participated, because you'll recognize there are some unique considerations for surgery that require specific consideration, but the Children's Center priorities could be really informed by these, and we'll undergo a rigorous strategic prioritization process, and we'll let that unfold, and you'll hear about it in a little bit. But these are the pediatric surgery priorities. Of course, the underpinning of clinical excellence, growth, innovation, education, and then marketing, access, throughput, staffing with an eye to quality at all times. That's what I wanted to share today. I appreciate the opportunity to be with you all today, and very much look forward to Dr. Banwell's remarks. I'm going to see if I can figure out how to unshare.
Thank you, David, very
Yes.
much. Once you do that, I can take over.
Yes. Just a sec. I may actually have to log out and back in because I've got a lot of screens, so I'll come back.
All right. See if I can make mine do that. All right. I will need somebody to tell me shortly whether you are now seeing my slides.
We do, but it's not in present mode.
How are we now?
Yep, good.
Wonderful. All right. I am extraordinarily excited to be here. Thank you all for joining. I know there are over 200 of you on this call, I believe. And I am truly honored to be here today and to take over as the new director of the Department of Pediatrics and co-director and pediatrician-in-chief of the Johns Hopkins Children's Center. Still have to practice saying all of that. As Maggie nicely mentioned right at the beginning of her remarks, the excitement of joining the Johns Hopkins family for me really rests with Johns Hopkins' mission which is something I've known about as long as I've been in medicine. And certainly all of you are aware that the clear mission of the Hopkins Center and the 4 pillars of excellence in clinical care, education, research, and then diversity, inclusivity, and equity rest on an incredibly strong support of more than 100 years of excellence in these domains. And it is on that platform that the next decade of work will rest. And like any great institution, there's always some room for renovation because that's what keeps us moving in a forward direction. So I mentioned that I wanted to express my personal gratitude to Dr. Maggie Moon for not only her leadership, commitment, and loyalty to the department, but her incredible generosity of information, welcome, phone calls, Zoom calls over the last several months as she has helped me prepare for my first week of work last week and for this morning. I also want to acknowledge David Hackham, who has been also an incredibly available partner to help me get ready for this, and I'm sure will be an invaluable partner moving forward, as well as the support executive leaders, Stacey Mann, Michael Panakia, April Taylor, Sherry Crawford, and others who not only have supported you as a department and the JHCC as an entity, and Dr. Moon and her leadership, but they have all made themselves incredibly available to guide me and provide materials invaluable in preparing for this role. So great thank you to the people that I am already very excited to work with, including and very explicitly all of you. So very important in thinking about an envisioned future is to have a roadmap. I firmly believe, and I said this in my remarks many months ago, that if you don't know where you're going, you will reliably not get there. And in order to achieve an envisioned future, I think about a roadmap, which is not a straight line. No direction can ever, no future direction can ever anticipate all of the twists and turns that will happen over the course of the next 5 to 10 years. But what we can do is set milestones and roadmap where we want that envisioned future to take us. And in so doing, provide a guiding path that allows us to recognize when we've deviated from the path, either because we've taken a better direction or because we've lost our direction and we need to get back. And so I will use this analogy throughout my remarks today and end with a plan for our upcoming retreat, which is where we will work together to really craft a strategic direction and strategic set of priorities that will guide all of us on this journey together. So step 1, I think in order to create an envisioned future, we need to actually get to know one another, and I most definitely need to learn from all of you. In creating a method to achieve that knowledge and to get engaged in understanding the hospital, the department, School of Medicine, and this community, a variety of steps are in place. So I've been holding one-on-one meetings with the current pediatric division directors, absolutely invaluable beginnings of many future conversations. So learning a lot about priorities, and we just had a department meeting where people shared that with each other. I will be attending all of the divisional faculty meetings. Well, let me phrase that differently. I will be attending at least one divisional faculty meeting in each of the divisions in the coming months so that I can actually get to know a broader representation of the department faculty. And then in a similar level, meeting with the JHCC department leaders and divisional leaders to have a broader footprint of the community here and hearing the priorities from a variety of perspectives. I've had the privilege of meeting with nursing leadership, and I had lunch last week with the clinical nurse specialists, and we'll continue to get to know our nursing colleagues who are, of course, invaluable partners in healthcare, as well as allied health leaders across the department and the institution. Equally important in terms of being effective in delivering the mission for child health is to also meet and work with the senior leaders that will be, of course, imperative in the approval and support for our mission. And at this point, I would also like to not only acknowledge the goal of ongoing interaction with the Dean DeWeese, Drs. King, Miller, Kevin Sowers, and others, but also thank them for their support in the recruitment process. And in that goal, I'd also like to just quickly thank Justin MacArthur and Gail Dommett, who led the search committee and were incredibly kind to me as I went through the journey of becoming the new department chair. Dr. Hackham and our leadership and I will be meeting, of course, on a very frequent basis, and we will be interacting with our other regional partners, as you see here, all of which will be very important as we learn and think forward. One of the things that's very important to me is to understand you as a children's center. So starting with the Heart Center, in a couple of weeks, I will be rounding as the least experienced person on the team with each of the areas in the hospital. So I'm going to start with cardiology, CICU, and the heart team. I will spend the morning rounding with each of you, learning from all of you, because I firmly believe that the best way to co-run a hospital is to actually understand at the grassroots level how a hospital runs. For those who aren't aware, my previous inpatient life was neurocritical care for the last 30 years. I've spent countless hours in the CICU, PICU, and NICU as a child neurologist. Now I'm going to do it as a pediatrician. And so I am really looking forward to directly interacting with you and your teams to better understand the hospital dynamic and emergency room, et cetera. I am very excited by the direction of the School of Medicine. The tuition-free or tuition support that has now been endowed is incredible. Opens up medical school access, I hope, for a broader community of individuals for whom the financial burden of medical school debt may previously have made that prohibitive. So it is now our responsibility as pediatric health providers to further engage those medical students so that they see pediatrics as their exciting future home. As some of you know, enrollment, selection of pediatric residency has actually been going down over the last 5 to 10 years, and we have an imperative to turn that around. I don't have to share why with any of you. We are all here for the same reason, which is we love what we do, and we have the enormous privilege of looking after children and their families. But we need to instill that pride and passion in the medical school student body, and I hope that not incurring significant debt will be one component that can be removed as people look at choices and career options. I'd like to get to know our trainees. I always feel that, and I can see my PEDS chief is on here, getting to know all of you is pivotal, because not only do I learn from all of you, and I will learn a great deal from all of you, but I also want to see where you want to go. You are the next generation of pediatricians, the next generation of pediatric subspecialists, and so I'm very excited to hear from you. So to achieve that, we will be having dinner. I will be offering a dinner each month for whomever's birthday happens to be that month. So I'm hoping over the course of a 3-year residency, I'll get dinner with you at least 2 to 3 times. So these will be birthday dinners with the director. I will attest that I have flagrantly stolen this idea from Dr. Giardino, who is the head of the residency program. Actually, the Department of Pediatrics at the University of Utah, where my daughter is a PEDS resident. But she has attested that these have been really fun ways for her to get to know the department director and to have a conversation about pediatrics broadly. So he knows this, I am actively stealing that idea, and you will see your invite very shortly. Those of you that missed the first 3 months, July, August, and September, divide yourselves between October and November, and we'll continue on from there. And of course, I'll be meeting with the chiefs. So we want to engage with all of you, and we'll be hosting a retreat in November. The exact date's just being worked out. And I won't go through all of the details of this right now in the interest of time, but the pivotal goal of a retreat is engagement. The goal is to have people come together. One day will be more heavily focused on the department and the School of Medicine side of our needs. The second day will be more heavily focused on the JHCC. We will have a formal facilitator, because it's often incredibly helpful to have someone whose professional job is to facilitate conversation, breakout groups with committed leaders. And the goal will be to create our priorities, 3 to 5 areas of core priority. Working groups will be derived from that, who will work further to take those priorities and flesh out specific strategic goals and milestones for each pillar. We will then socialize a draft version of this through town halls, an online commentary period, and of course, in complete collaboration and partnership with our School of Medicine and the health system. And by January, my goal is that we will have, to start with, a very clear, crisp 5-year strategic plan for both the department and the JHCC. And I don't imagine that they will be precisely the same. Obviously, there's broader and different goals between the two, but our goal is to have a very clear vision for where we're going, and it needs to be really informed by all of you. So I will be asking for your engagement in this process in a multitude of ways, so that this final version is something we have created as a group. Step 2 is expanding what is already a strength, which is clinical excellence. I have listed areas of priority, not because you don't already know this. I know you do, and I know that they all exist here. And we just heard from Maggie some wonderful examples of everything that's on this slide. But I was wanting to share that these priorities are indeed priorities that will be invested in both intellectually and financially, and in terms of personnel and growth. I won't go through each of them in the interest of time, other than to just call out particularly the body and mind one. Psychiatry support, psychology support for our patients and their families could not be more pivotal. I don't need again to share this with the group, that I'm sure you all know this, but 30% of our teenagers endorse depression. Suicidality is alarmingly high. And the new ACGME guidelines specifically are going to require more education in psychiatry and psychology for our pediatric trainees, recognizing this imperative. How we do this is something that I'm very eager to get advice on, but something we really need to think through. Advanced care initiatives. One of the questions asked of me, and I will be turning it around and asking it back to you, is what are the top areas of medicine for the next decade? There's little doubt that cell and gene therapy is at top of many people's lists for many different disorders. As someone that has looked after patients with neuromuscular disease, it is an incredible reality to see infants treated with gene therapy who would otherwise have succumbed from spinal muscular atrophy. My first patient that I treated is now doing ballet and swimming and regular swimming lessons, and walked to the runway at our fundraiser just last year. And she had SMA type 1. So that's our goal for many of the conditions that start in our childhood years, or many that are going to be treated that will just never start in teenagers or adulthood. So absolutely a top priority, and a lot of discussion on how we're going to deliver on that. Enzyme replacement, in utero treatment broadly, robotic surgery, and others. We have challenges. There aren't that many children being born anymore. The birth rates are going down. That means that, we have to think about how we're going to grow as a pediatric department. And the babies that are being born may or may not be healthier than in the last decade. And that challenges exactly where we need to go. To achieve that, we have a variety of things that we can do. Clearly, we need to be, first and foremost, relevant to our community. The healthcare we provide, the services we design, our goals and mission, the hour needs to be a community-focused hour, or we're not going to resonate. We won't be that invaluable health partner if we don't actually appreciate the priorities of our own constituency and our own immediate community. But we also have to be the go-to regional provider. I know that the command center launch has been invaluable in being available and providing a space and place and mechanism for providers to reach out and choose Hopkins. We need to make that absolutely the best experience possible. And obviously, we have to have the beds for those patients. And I do realize that's a challenge, but becoming the go-to regional provider is pivotal. We need to have programs not only that cover the broad breadth of pediatric healthcare requirement and need, but are also programs, at least a sizable portion, that are there as a pivotal beacon to draw families for programs that don't exist elsewhere, or that exist here at a much more family-centered and superior way. That's our goal. It's always been the goal, and I know that it's something that's been achieved in many, many levels, but there's still room to expand. And when we think about expanding, we want to think about international partnerships and options. And of course, I'm a North American, Canadian by background, and I put this on here because I think Canada is a collaborating partner that we might not fully have explored. And the Canadian healthcare system is challenged by its national healthcare model, which on equity access is terrific, but when you don't have enough providers, it unfortunately is leading to lack of access literally across the country. and certainly for critically ill children. So could we be a more invaluable partner to our immediate northern neighbor? And of course, others, and I don't mean to ignore our southern neighbors, international neighbors, broad community, particularly. We have to grow as a workforce. And in order to do that, we need to start early. We need to think about infusing a love for pediatric healthcare, as I mentioned before, in high school, in our undergraduate campus, and obviously in the medical school. I won't have time today to talk about our high school scholar program that we created about 10 years ago at CHOP. But if you ever want to be inspired, work with a 15-year-old whose eyes are about this big because they're seeing a future that they hope they can make be a part of theirs. It's an amazing way to bring tomorrow's learners to the forefront when they're making even earlier decisions. We need to make sure our educational mission is inspirational. We've talked a bit about that. And increasing and diversifying our workforce remains and will always be a top priority. Reimbursement is critical, both for the work we do and the faculty and the staff that we support. And we will have a lot of conversations about compensation in the coming months and years, as everyone has to address the pivotal need to compensate our faculty and to be paid as pediatricians commensurate with the work we do. Collaborative healthcare opportunities continue to expand. We grew a lot in telehealth in the pandemic. We learned how to do things differently and amazingly quickly. But a lot of that's pulling back as people go back to old practices. Is that still going to continue? What is the role for e-consult? What is the role for community chat groups for broad education around a new healthcare initiative, just to get people up to speed so you don't repeat the same 30-minute starting point with every family when maybe a broader educational initiative might be relevant and effective. We need to be rewarded. Why do we do what we do? We mostly don't do it for compensation. We don't do it for glory. We don't do it for a title. We do it because it's inspirational, because we know it makes a difference, and because we work with people who share that value. So team-based care and innovative care together is absolutely essential. And then finally, we have to retain all of you, and we're not in the same environment as 30 years ago. We need to think differently about nights, weekends, hours, flexibility, alternate work arrangements, because that's the reality of the next decade of workforce. So accelerating discovery. This is just a graphic of work that I ran at CHOP, but it highlights what we will be expanding here in partnership with the adult precision medicine team and a variety of others, which is to create and really get to a point, in my view, where we would apologize to any family that we could not offer engagement in discovery work relevant to their child. That's a broad mission, and it doesn't mean every family wants to do that. That's not my point. My point is we should be able to offer it. And if we want to have that offering, that can include everything from input, high quality patient data in the first place. So building Epic systems and smart forms and data into our own electronic record from which high quality information at the population level and personal level can be abstracted in the future. There's no reason we can't do that except for time and innovation. And those are things we can have. But when you do it, you can then have an incredibly valuable electronic health record that is really becoming more of a data system. And you can't pull out of the current record data that was never put in correctly or at the highest quality level in the first place. So how to do that? Thinking about biospecimens, comparative biology, and comparative ability to look at why one person's immune system is different from someone else's is absolutely essential, for example, if we're going to have specific therapeutics for children in an immune crisis. But we have to have the samples in the first place. So we have and will resource now much more active engagement with biological sample procurement, and we will integrate across a variety of systems to make that data accessible and usable. So Kaiser and others are going to be very busy helping us with our integration. And I won't, in the interest of time, talk about imaging, but that's also essential. To kick some of this off, we'll be starting a new grant program. The first will launch this year. So these are going to be what I will currently label, and we can rename, Centers of Emphasis and Translational Research Grants. So these grants are about $3 million over the course of 3 to 4 years. Each of these grants, these are internal, will be to fund innovative translational clinical programs. And the key word in there is programs. This is not a single labs project. This is an integrated program grant. It needs to be crystal clear that this is an unmet new priority. It has to have a translational component. Ultimately, and from inception, we will design a sustainability model for these programs, which will include fiscal modeling, partnership with our marketing teams, our growth analyses, putting into the program before it even starts the best possible way to build it so that it can become sustaining and innovative and expand. And some of that expansion could be NIH funding and grants. Some of that expansion could be a variety of other philanthropic opportunities, could be that the program leads to new inventions for which there may be downstream financial growth. All of that can be included, and you'll see a great deal more about this, but the first of these cycles will start this year. And then ultimately, if we want to have world-class research expand and continue to define Johns Hopkins, which it has for over 100 years, one of the ways to do that is to really enable it. And so we will be building toward the creation of what I'm referring to as the Johns Hopkins Pediatric Research Institute. The goal will be to start with a task force to define what's here. And I've heard about the BEAD program. There's amazing things already here. So this is not starting from zero by any stretch of the imagination, but it's to bring all of the groups that facilitate research and research innovation to one home, to do a needs assessment to determine what might be missing, what we might wish we had, to design what that integrated, and I've put quotes around what I've drawn there are taken from clip art as a building, but I'm not against potentially getting to a building, but that's not the primary objective. It can be a group of individuals working collaboratively together, but it will be very helpful to fundraise forward to really create this entity as well as other resources bringing this together. This will partner with our precision medicine initiatives. It will partner with our patient-facing engagement initiatives to have a higher focus and expansion on discovery science. And of course, not on this graph, but pivotal, is to partner with all of our training programs, both currently existing T32s, K Awards, and others, diversity supplements, which will be essential, as well as being a home to integrate across basic translational Q quality related and other research initiatives. Everything that I said aligns very nicely with the recently shared slide, thank you, Maggie, on the multi-year priorities of the School of Medicine. I won't read them in the interest of time, but if you look through each and every one of these, and they were highlighted already by Maggie early in this presentation, everything we just said in the last few minutes, it aligns with the strategic goals of the School of Medicine and the hospital system and the university, which is essential. So to put it together, the goal is to have a modified version of what has always been a pivotal, crystal clear, and aspirational mission. So I've rephrased it just a little to be empowered, family-centered, evidence-supported clinical excellence, partnered with translational innovation based on cutting-edge research, basic translational QI, and disseminated to tomorrow's leader in our diverse community. Under that, the supports that are already here will include investment in our clinical innovation, thinking and about our recruitment strategic plans very, very carefully with a diverse lens and fulfilling our workplace diversity goals. I will currently refer to it as the Children's Center for Biological Discovery and Precision Medicine. Everything I have on here with names, we can rename if someone has a one that comes up with a clever acronym, which I am not particularly talented in, but we will basically bring it under that umbrella. And then with a goal of over the next several years, creating a pediatric research institute as well. So that was a lot in about 18 minutes. I do speak quickly, but I am happy to answer a few questions. And I know some of you will have to log off, but I do first and foremost wish to thank you for your attention. And I can answer any questions if people have them now or over the course of different discussions. And I don't know how to see if anyone has their hand up.
And Brenda, that was amazing. I'm so excited for the future building on such a storied past.
Thank you, David. All right. Oops. I don't
Folks,
know if
please-
people have,
Yeah, feel free to shout out if you wish, or use the chat.
I assume I have stopped sharing my screen. Is that correct, David?
I still see your last slide, actually. So I think,
Okay. I'm trying to get that to turn off.
yeah, I think they,
Don't know why I can't get that to turn off, but
yeah, I couldn't do it either. It's
I think you had to log out to get that to.
yeah.
Yeah. All right, well, that's challenging. So if you're seeing my last slide, I hope it's inspiring.
It's very interesting.
I don't know whether people have direct questions. If they don't, that's fine. We would definitely will want them. As I mentioned, the retreat was going to be a highly engaged experience for all of you, both at the time of the retreat and in the following months, where we will be asking for your really in-depth thoughts about the future. If you can see yourself 5 years from now, look backward and say, how did I get here? That's going to be the model that I think will help all of us achieve that same aspirational success. So it will push you not to see where you are now and what you have to jump over to get there. Not that that's not valuable, it's just not necessarily as helpful sometimes as seeing yourself where you wish to be. And then we can deconstruct every step that's required to have achieved that vision. So I'm definitely someone that likes to start with where I want to be first and enable that vision. And I hope to help all of you achieve that goal as well in partnership with the amazing leaders that are here, with Maggie and the team that have done so successfully over the last several years. And of course, building on the legacy that defines this institution and the department. So thank you everybody for your kind attention. I look forward to getting to know all of you a great deal better. Thank you for the warm welcome and for including me in the Hopkins family. And we wish you all a great rest of your day.
Have a great day, everyone. Thanks.
Thanks, everyone.
Yeah.